Brachycephalic dog breeds are characterized by their shortened skulls, flat faces, and compact upper airways, giving them their signature, smushy-faced appearance. These breeds are beloved worldwide for their expressive eyes, distinctive personalities, and strong human-animal bonds. Despite their charm, their unique anatomy predisposes them to certain medical challenges. Bulldogs, Pugs, French Bulldogs, Boston Terriers, Shih Tzus, Pekingese, and Boxers fall in this category. Brachycephalic breeds are beloved for their unique appearance, endearing behavior. Their specialized anatomy, however, requires proactive veterinary care, especially for breathing, eye health, dental issues, thermoregulation, and skin folds. With proper management, these dogs can live comfortable and fulfilling lives.
Brachycephalic Obstructive Airway Syndrome. Stenotic nares are abnormally narrowed nostrils that restrict airflow at the entrance of the airway. The elongated soft palate is too long relative to the shortened skull, causing it to hang into the airway. Everted laryngeal saccules. Excessive negative airway pressure from chronic obstruction causes the small tissue pockets just inside the larynx, saccules, to turn outward into the airway. A hypoplastic trachea is a congenitally narrowed windpipe that reduces the volume of air reaching the lungs. Redundant pharyngeal tissue. Excess soft tissue in the back of the throat further narrows the already compromised airway. Laryngeal collapse. Chronic increased effort to breathe weakens the cartilage of the larynx, causing it to lose rigidity. Stenotic nares are abnormally narrow or pinched nostrils that restrict airflow as a brachycephalic dog or cat breathes in. Because these breeds already have shorter skulls and crowded upper airways, narrowed nostrils significantly increase respiratory effort. Affected animals must generate stronger negative pressure to pull in air, contributing to the progression of other BOAS components: elongated soft palate, everted saccules, laryngeal collapse. Surgery is the gold standard and significantly improves airflow and long-term quality of life. Common surgical techniques are Allay wedge resection, vertical wedge resection, Trader's technique, allopaxy, and laser or electrosurgical techniques. The ideal time is early in life, 4 to 12 months, before secondary airway changes develop. Medical management, supportive only, not curative. These help reduce airway inflammation but do not fix the anatomical narrowing. Weight management reduces respiratory effort. Activity modification, avoid heat, excitement, and strenuous exercise. Anti-inflammatory medications, short courses during crises. Environmental management, cooling, harness instead of a collar. Monitoring for signs of BOAS progression, increased snoring, regurgitation, and collapse episodes. Medical management is supportive and temporary. Surgery is recommended for moderate to severe cases.
An elongated soft palate occurs when the soft palate is too long for the shortened skull. The excess tissue extends into the laryngeal opening, partially blocking airflow during inhalation. This obstruction creates increased respiratory effort, snoring, gagging, stertor, exercise intolerance, and can contribute to the progression of other BOAS components. Surgical shortening, staphylectomy, soft palate resection, is the gold standard treatment. The excess portion of the soft palate is surgically trimmed to a normal length, improving airflow and reducing upper airway pressure. Common surgical techniques are traditional scalpel or scissors resection, CO2 laser soft palate resection, electrocautery or bipolar vessel sealing devices, and folded flap palatoplasty, FFP.
Everted laryngeal saccules. Everted laryngeal saccules occur when the laryngeal saccules, small mucosal pouches located just inside the larynx, are pulled outward into the airway due to chronic, increased negative pressure from obstructed breathing, as seen in BOAS. This protrusion further narrows the airway, worsening respiratory noise, effort, and heat exercise intolerance. Everted saccules are considered an early sign of BOAS progression, and often coexist with stenotic nares and an elongated soft palate. Treatment options: surgical removal, sacculectomy. Primary treatment. Sacculectomy involves trimming or excising the everted mucosal tissue using Metzenbaum scissors, CO2 laser, electrocautery, and microdebrider. This immediately reduces airway obstruction and improves airflow.
A hypoplastic stenotic trachea is a congenital condition in which the tracheal lumen is abnormally narrow due to underdeveloped tracheal cartilage rings. This narrowing reduces the volume of air that can pass through the windpipe, leading to increased respiratory effort, exercise intolerance, noisy breathing, and greater sensitivity during anesthesia. It is most commonly seen in English Bulldogs, but also occurs in other brachycephalic breeds, such as French Bulldogs, Pugs, and Boston Terriers. Medical management. Since the condition is congenital and the trachea cannot be enlarged surgically in most cases, treatment focuses on supportive care and reducing airway stress. Weight management, environmental control, anti-inflammatory therapy, bronchodilators, and cough suppressants.
Redundant pharyngeal tissue refers to excess soft tissue in the back of the throat, pharynx, commonly seen in brachycephalic dogs due to their shortened skull anatomy. This extra tissue crowds the airway, increasing turbulence, vibration, snoring, stertor, gagging, regurgitation, and breathing difficulty. It often contributes to or exacerbates BOAS, especially during excitement, heat, or exercise. Chronic airway obstruction can cause these tissues to swell, further reducing airway diameter and worsening clinical signs. Medical management. Weight management, avoid heat and overexertion, harness instead of collar, environmental cooling, anti-inflammatory medications, oxygen therapy during crises, treat coexisting GI disease, reflux, hiatal hernia, to reduce airway irritation.
Redundant pharyngeal tissue rarely exists alone. It is typically part of the multi-level airway obstruction seen in brachycephalic patients. Surgical correction aims to increase pharyngeal airway diameter, reduce turbulence, and prevent progression to laryngeal collapse. Because pharyngeal tissues are delicate and prone to swelling, surgery is performed by experienced soft tissue or specialty surgeons, and often combined with other BOAS procedures. Indications: pronounced soft tissue redundancy, tissue obstructs airflow, severe snoring, regurgitation, or stertor not resolved by standard soft palate nair correction. Risks: postoperative swelling is the biggest risk, hemorrhage, and temporary worsening of obstruction during recovery. Therefore, intensive postoperative monitoring is required.
Laryngeal collapse, advanced BOAS. Laryngeal collapse is a severe end-stage consequence of chronic upper airway obstruction, most commonly due to long-standing, untreated brachycephalic obstructive airway syndrome, BOAS. Continuous increased negative inspiratory pressure weakens and deforms the arytenoid cartilages and supporting structures of the larynx, causing them to fold inward and significantly obstruct airflow. Stages of laryngeal collapse. Stage 1. Eversion of laryngeal saccules. Stage 2. Medial deviation of cuneiform processes. Stage 3. Collapse of the corniculate processes/arytenoid cartilages. Near complete airway obstruction. Stage 3 is considered life-threatening and often irreversible. Arytenoid lateralization, tieback, is a commonly used surgical procedure in collapse.